Hello everyone, welcome back to our online class. Every year in the US, pressure ulcers affect more than 1 million patients in acute care and nursing homes. Treatment-related costs exceed $1 billion annually. There are many skin problems in clinical practice, the most common of which is pressure ulcers. Now, we are going to discuss this issue. Let's start with a case. A 65-year-old woman with breast cancer and lumbar metastasis was bedbound due to pain. Although we took a lot of measures to prevent the occurrence of pressure ulcers, unfortunately, she finally developed sacral sores. What causes pressure ulcers? How to prevent and treat this skin is our topic for today. We have 3 learning objectives. First, describe causes of pressure ulcers and high-risk group. Second, compare clinical manifestations of various stages of pressure ulcers. Third, educate patients to take effective measures to prevent pressure ulcers. Let's first look at the definition of pressure ulcers. Long-term compression of local tissues, causing decreased blood circulation, persistent ischemia, hypoxia, and nutritional deficiency results in local tissue damage and necrosis. Pressure ulcers is the consequence of injury to the skin or underlying tissue, usually over a bony prominence. Now, we shall go through the causes, stages, prevention, and treatment of pressure ulcers. The formation of pressure ulcers is a complex pathological process which involves the degeneration and necrosis of skin tissue caused by the combined local and systemic factors. The first is mechanical factor. Excessive unrelieved pressure is the primary cause of pressure ulcers. Shearing force is a combination of friction and pressure. It occurs commonly when a patient assumes a sitting position in bed. Friction is a force acting parallel to the skin surface. Pressure ulcers are often caused by the simultaneous action of 2 to 3 forces. In addition to mechanical factors, there are other causes of pressure ulcers. Individuals who are immobile or have limited general mobility are predisposed to pressure ulcers. The equator of people with fecal and urinary incontinence can irritate the surrounding skin, making them prone to skin breakdown and infection. Prolonged inadequate nutrition causes weight loss, muscle atrophy, and loss of subcutaneous tissue. These 3 conditions reduce the amount of padding between the skin and the bones, thus increasing the risk of pressure ulcers development. There are several other factors contributing to the formation of pressure ulcers. For example, advanced age and improper use of medical equipment aids. In 2007, the US NPUAP discussed and updated the more detailed pressure ulcer staging criteria, dividing pressure ulcers into 6 stages, from intact skin to deep wound. Pressure ulcers are staged based on clinical characteristics. Stage 1, non-branching erythema of intact skin. Stage 2, partial thickness skin loss, but does not involve muscle or other deeper tissues. This can appear as an abrasion, blister, or shallow crater. Stage 3, full thickness skin loss, which may extend to, but not through the underlying fascia. Stage 4. Extension into deeper tissues, including muscle or bone with possible exposure of supporting structures such as tendons. Stage 5. Full thickness skin or tissue loss. Depths unknown, also completely obscured by an or in a wound bed. Stage 6 may further evolve and covered by skin eschar. Prevention is more important than treatment. We should pay attention to skin overlying bony prominences, where external pressure can easily traumatize the skin. A comprehensive assessment of common pressure sites can effectively prevent pressure ulcers. The first thing we should do is a comprehensive assessment of the whole patient. We should evaluate the overall status such as general health, nutrition and mobility, and local condition of the skin. We can also use some risk assessment tools to evaluate a patient's risk of developing pressure ulcers. The most common tool is Braden scale for predicting pressure ulcer risk. It consists of 6 aspects: sensory perception, moisture, activity, mobility, nutrition, and friction and shear. A total of 23 points is possible, and an adult who scores below 18 points is considered at risk. Below 12 points is considered at high risk. Another tool is Norton scale, and we won't go into details here. Who can tell me the common pressure signs in supine position? Yeah, they are back and head, scapula, elbows, sacrum, and heels. Then we have ear, shoulder, elbow, knee, and malleolus, which are the common pressure sites in the lateral position. Similarly, you can see the risk areas in prone position. We need to find out common pressure sites in different positions so that we can prevent pressure ulcers. To reduce the likelihood of pressure ulcer development, nurses need to take preventative measures to maintain skin integrity and instruct patients and caregivers about prevention. To protect the patient's skin, we should aim to reduce mechanical factors, promote skin blood circulation, enhance general nutrition, and provide health education. We nurses should be diligent in our work. Frequent observation, reposition, massage, and scrubbing, as well as frequent arrangement of beddings. This can effectively prevent the occurrence of pressure ulcers. The treatment of pressure ulcers should focus on local measures supplemented by systemic management. Pressure ulcers are a challenge for nurses because of the number of variables involved. The numerous measures advocated include relieving or eliminating the source, optimizing the environment, enhancing host immunity, and providing education. First, we should reduce mechanical factors by decreasing pressure, shearing force, and friction. Encourage high-risk patients to change their positions every 2 hours. If they are unable to reposition themselves, offer help and use equipment aids if needed. Document the frequency and posture adopted in repositioning. For those sitting in a chair or wheelchair, teach them to shift every 15 minutes or help to change their positions every hour. Provide devices such as positioning pillow or a high specification foam mattress to minimize trauma to pressure areas. If there is a pressure ulcer, We should assess and measure the size, including length, width, and depth, amount of acetate, stage of the ulcer, and integrity of surrounding skin. Then we need to clean the wound, eliminate excessive moisture, and see whether the wound is infected. If so, we'll use a disinfectant depending on the acetate, debride necrotic tissue, and apply the appropriate dressing. Enhance host immunity, correct underlying problems such as diarrhea and urinary incontinence to reduce the moist environment. Assess and manage pain. Pain causes decreased activity, which hinders a person's ability to change positions independently and relieve the pressure. Pay attention to the nutritional status. Because an inadequate intake of calories, protein, vitamins, and iron is believed to be risk factors for pressure ulcer development. Education of patients, families, and caregivers is the key to prevention and successful management of existing pressure ulcers. They need to understand the causes, contributing factors, prevention measures, significance of nutrition, and so on. Now let's summarize. The major goals for patients at risk for pressure ulcer development are to preserve intact skin and to avoid potential risk. The four major areas in which nurses can help develop optimal conditions are proper positioning, providing sufficient nutrition and hydration, prevention wound infections, and maintaining moist wound healing. That's all for this session, and these are my references. Bye-bye.